Hello, everyone. My name is Dr. William Orr. I'm a pediatric cardiologist at St. Louis Children's Hospital and Washington University. I have my colleague, Dr. Jason Newland, here with me from the Infectious Disease Division. And we have been asked to answer some very common questions about COVID-19 in our pediatric patients, and specifically how COVID-19 and this other multi-inflammatory state syndrome in children is affecting the cardiovascular system in pediatrics. I do have a set of questions that I'm reading off screen, which I will be answering with Dr. Newland. So hello, Dr. Newland. Thank you for joining.
Hello, Dr. Orr. I like how to refer to you as Billy. I appreciate the opportunity to speak with you and your audience.
Yeah. So I'm going to have you answer the first couple questions because I think you have a better idea. So the first questions are just regarding the impacts of COVID-19 on peds versus adults, and then where did this MISC, which stands for the multi-inflammatory syndrome in children, come from, and how rare is it?
So let's first talk about this new virus that we've all got to know quite well since it first kind of appeared at the end of 2019. So this virus, SARS-CoV-2, causes the illness that we refer to as COVID-19, which stands for Coronavirus Disease 2019. So when you hear us say COVID-19, we're referring to the people that are sick with the SARS-CoV-2 virus. Now, its impact on children has been much, much less than adults. If you look at data from the United States and look at the positive patients with the SARS-CoV-2 virus, children only make up about 2% of those cases. And among those cases, most of them have mild illnesses, meaning they don't go to the hospital, they might have a cough, they may or may not have fever. Now, what we have learned about those who end up in the hospital, that typically, probably 70+% of them will have what we call underlying conditions. So they could have a cardiovascular disease that Billy, Dr. Orr knows much more about than I do, but also obesity appears to be a risk, as well as diabetes. In some of these older children, though, we're learning more and more about diabetes and how that impacts from a children's perspective. And then lastly is usually chronic lung disease and potentially immunosuppression. We are still learning more and more about that. The common symptoms of children impacted by this virus are fever occurring in about 50% of the cases, cough. The fever and cough combination is probably in 70% of the cases, but we also see symptoms like vomiting and diarrhea that occurs in about 15% of cases. Loss of taste and smell, which we've all been learning about with this virus, does occur in children. And so that's the common symptoms. Now, let's talk about this new syndrome, MISC, or the multisystem inflammatory syndrome in children. This is an interesting story, and it was first reported out of England kind of toward the end of April. And then on May 14th, the Centers for Disease Control and Prevention, or our CDC, gave our kind of health alert and says, okay, these children look like the following. Number one, they're severely ill and they need to be hospitalized. You all have to know that. And also number two with that is that this is extremely rare. I've already told you that, number one, children are less likely to be impacted by this virus. And then number two, you're less likely to even be admitted to the hospital if you are a child, because most of them have mild disease. Now, MISC, again, definition means you got to have fever, and these fevers are typically high. I'm saying over 102. And then you have to have the signs of inflammation, and we have lab tests to show people have inflammation as well. And now they then can have heart involvement. They could look like a syndrome we know as Kawasaki disease, though it's not the same. There seems to be some kind of notion there. And lastly is that they typically have had either contact with someone that's had COVID-19 or they test positive for the virus by a methodology that we use to look for the DNA or RNA of the virus, or they have antibodies. And what's most striking about this syndrome has been it's shown up both in the United States and parts of the United States, approximately 4 weeks or so after we see the initial peak of the SARS-CoV-2 illness. So that's what it is. I think I want to reiterate, this is rare. We are keeping an eye out about it, and we want you all to be obviously aware of this. And the key symptoms for this, lastly, is fever, prolonged, usually 4 days or more, as well as most children will have some vomiting and diarrhea, and potentially some other symptoms like rash, eye changes. So that's kind of the long version of MISC.
Yeah. Well, so here's a follow-up question. You mentioned that the prevalence of getting COVID-19 in kids in the United States is about 2%. And then you keep saying that this MISC is rare, right? But you're not giving a number. And I would assume that's because there haven't really even been enough cases yet to even start to try to say what the percentage or the prevalence rate of that is. Would you agree?
I completely agree, Billy. Thank you for clarifying that. We don't have the sense of what that number is, and that's why the CDC has asked us, if you've had a potential case meeting our definition, then we're going to get a better idea of what that number is going to be. Right now, we know we've had a couple in our area, and we know that in New York, they've probably had more because they had more disease, but nationwide, we still don't know.
Correct me if I'm wrong, it's also now something that we have to report to our local health department, right? So
Correct.
That we can learn kind of more about this. So now we've got something that's rare to affect kids, which is good, I think, for everybody that has kids. And then this really scary thing that can be a late presentation is also extremely rare. And then it sounds like what you mentioned is that, multiple organs can be involved, but there's not necessarily a certain pattern that they have to have. Like they could have cardiac involvement, which we'll talk about, or they couldn't have cardiac involvement. They could just have respiratory involvement, et cetera, right? So like being overly paranoid that your kid is necessarily going to have cardiac manifestations if they get a cough is probably a pretty unrealistic thing overall.
Correct. And I think the big point here is that if you have a child that's had fever that's over 102 for 3 or 4 days, the best people to talk to is your pediatrician and your clinical providers. Our clinicians in the offices they're in, our pediatricians, Billy, I know your wife is a general pediatrician. Their offices are set up and safe for you to be cared for, and they have processes to make sure that your child is getting the care they need to be able to identify whether or not the next steps are needed if your child would have this condition.
And I think you just mentioned another thing is that they're safe to go to. And I would imagine there's probably still some fear out there about going to, highly populated areas like cities or even your doctor's office, which I think is something that most doctors, pediatricians would recommend against and say, hey, look, I know for a fact that my wife's practice and most of the practices around St. Louis do have multiple things in place where if you come in with the even potential of having COVID-19, you're going to be kind of set off to the side so you're not with somebody else. And that being said, if you're trying to bring your kid in for just a well child check or something else, maybe an ear infection, you don't necessarily have to be worried about being exposed to somebody that comes in with possible COVID. So I think that's a super important part to stress because I think it's important to not take your kid into the doctors when you're worried about something. So I think I'll try to answer some of these questions, and Jason, Dr. Newland, jump in and help me. So one of the things you had mentioned and one of the things that was asked was, how is this related or connected to Kawasaki disease? So Kawasaki's disease is one of those things that's overlapped a lot by cardiology and infectious disease. Commonly it's followed by our infectious disease doctors. The patients usually present with fever for 5 days. They have usually an array of other symptoms. They can have rash. They can have their mucous membranes, their lips, their tongue can kind of get red and beefy and inflamed. And then usually the reason the cardiologist gets involved is because for some reason, and we don't 100% know yet, there's a lot of research that's been going on for many years about this, but it's still one of those unknowns, is that this Kawasaki's disease can target the coronary arteries. The coronary arteries are the arteries that come off of your aorta that supply blood to the heart, and if they get clogged, they can cause a heart attack. So the reason that pediatric cardiologists get involved is because Kawasaki's disease can cause dilation, and if it's dilated, there can lead to thrombosis or a clot that forms into the coronary artery, and that could be a potential for a heart attack later. This is still, of all the Kawasaki's cases that happens, again, something that's super rare. And this is something that we're seeing it's following this Kawasaki-like because we are seeing the same coronary artery changes in this COVID-19 post-inflammatory MISC syndrome that we do in Kawasaki's disease. The weird thing is that Kawasaki's disease is usually something you see in our toddlers. And this Kawasaki-like disease we're seeing related to COVID-19 is happening at an older age, with a mean age of about 10. And so it's a little bit difficult because we try to follow the guidelines from the Kawasaki's research, but again, there's really no great research for these new patients. And so it's extremely interesting. We obviously are going to do everything we can to make sure, the risk we're making sure we're treating everything. But that is why people are calling it a Kawasaki-like, is because you get this inflammatory phase, and then you have coronary artery dilation afterwards. Dr. Newland, I don't know if you want to comment more on that.
You did a great job. I would just say that there's a lot of debate among the experts whether or not we're calling it Kawasaki-like, and you can find some people says don't use that term for this, but most important point here for our viewers is that we're still learning a lot, and we have ideas of how we should be treating these children, and I think we will know more here in the coming months.
And I think that's important because people are probably wondering, like, well, what is everybody doing as far as studying? And most of the literature you'll see is for adults because there's just more adult cases. But actually, there are multiple multi-institutional studies that are being developed. Some funded by the NIH, some are just groups getting together to answer these exact questions, to collect more data, to see what we're seeing, to try to figure out what the prevalence is, how people are treating them, how we should be treating them, how closely related is it to Kawasaki's, is it not, et cetera. So I think over the next few months, we're going to have so much more data and so much more guidance that hopefully, all these questions can be answered more concretely. The other question that came up is these patients may not develop coronary artery dilation. They may just develop decreased heart function with this inflammatory phase. And there's a couple theories on why that happens. Again, nobody knows for sure. And really, we treat these patients if they have decrease in their heart function similar to any patient that would have myocarditis. And myocarditis is just inflammation of the myocardium, the heart muscle. There are lots of viruses that can cause this, and I think this virus is just now added to the list. And so typically those patients are going to be your really sick patients that are in the hospital. And honestly, the best treatment for that is supportive care. And supportive care just means giving them the oxygen they need, helping them breathe if they need it, helping their heart squeeze. Maybe they're on a continuous medication to help their heart muscle squeeze. But supportive care is really the best and only treatment for decreased function. There's yet to be anybody that's needed a heart transplant because of this that I know of. Theoretically, you could be on advanced life support if your heart function got bad enough. But I think it goes back to if you present to the hospital with these symptoms, there's going to be a very large team that's going to be taking care of your child, including infectious disease, critical care, cardiology, that's going to be making the decisions on what, if anything, is needed.
And I would say that's important here that you just mentioned, Billy, and that's, the children that have had this condition, this MISC, have done well. 99% of them appear to have done extremely well, and that people need to be rest assured by that.
And that's what's interesting, and I think we're going to learn more about that. Is if they do have any type of cardiac dysfunction, we'll see a decrease, and then typically a few days after onset, you'll start seeing, as everything else is recovering, you'll see the heart function recover as well, as kind of the inflammatory phase where the inflammation overall is going down, and the respiratory status is getting better. We're seeing the same thing with the heart, so it is reassuring for sure. Now, I think it goes back to the questions, well, how can I tell if my kid is at a higher risk of developing these cardiovascular complications? And again, extremely difficult. I think if there's any pre-existing conditions, heart failure, if your kid is on heart failure medications, if you have high blood pressure, which is seen in the adults, if you're being treated for diabetes, if you do have a kid who's on a statin or a cholesterol medication, overall, I think their health, they're at a little bit higher risk. We have yet to see this COVID-19 has not necessarily targeted our congenital heart population specifically. We haven't seen a spike or a skewed data that all of our congenital kids or single ventricle kids, et cetera, have come in with this. In fact, I can only think of maybe one that has been previously followed by cardiology here that came in with this. So I don't necessarily think they're more at risk, but I do think that if they have a previous heart condition or they've had cardiac surgery, then if they were to get it, they may have a higher likelihood of getting sicker for other reasons. Not necessarily because of the virus, but just because of their overall health in general. Other questions, describe how physicians are attacking this on a case-by-case basis and developing the treatments as time passes on. Jason, what are the recent treatments that are?
Yeah, the treatments is interesting. So because of the kind of relationship or the similarities with Kawasaki disease, what we have learned from those who have seen a lot more cases is that they use this medication, or really a blood product called immunoglobulin. And we call it IVIG, which stands for intravenous immunoglobulin. So most places I know of, when they have one of these children meeting the definition, will give the immunoglobulin. Additionally, they will also use medications that will make the immune system be suppressed or to knock it down because it's overreactive, because we're thinking that this is immune mediated. So there's different what we call biologics that people have talked about using, including things like anakinra has been talked about, steroids have been talked about. These sorts of medications are still being looked at, and different people have different views on how this is treated. And we'll learn more.
I think the last kind of question that we were given, and a good way to kind of end this segment, is what recommendations would you give parents who see symptoms in their kid, which I think we've already touched on, and then what symptoms should they look for? And again, I think the most important thing is that pediatricians know about this. This is not just something that specialists know about. Pediatricians are all over this. They've definitely been impacted and had to change the way their practice model is. And so absolutely do not be afraid to talk to your pediatrician, call them. And I would just recommend the same thing I recommend to all the parents, is you're the expert on your kid. If there's anything that your kid is doing that looks odd to you or abnormal, especially if they've had exposure to someone with COVID-19 or had coronavirus, I would have a very low threshold to call the pediatrician, and your pediatrician will be able to do an excellent job to triage your kid if he or she needs to go to the hospital or to get tested, etc. Dr. Newland, I don't know if you have.
Yeah, I would just add that for those of you that are concerned about if your child could have this MISC or the multisystem inflammatory syndrome, the things to look for are fever, that's typically high, when I'm talking over 101 degrees Fahrenheit for 3 days or longer. Typically in the cases reported, it's 4 days. So that's one. Number two, if they have vomiting and diarrhea with that, with those fevers, that's the second one. And then if they had some kind of cough illness, I would. But as Dr. Orr stated, call your pediatrician if you're concerned.
All right, thank you, Dr. Newland, for joining us. Hopefully this was informative to somebody out there. And, we're always here if anybody needs anything.
Yep. Send us questions. Thank you.